which and features which you might not see in other machines, which you see in Hamilton only. So there are other Hamilton models as well, which come from Hamilton C1 and C3 and C6. So C6 being the most highest and high-end model. So I'll give you a basic machine orientation and the brand. Hamilton Medical is from Switzerland, so it is made in Switzerland. So in terms of the quality and everything is very robust. And Hamilton C6. Why C6? Because there are different models: C1, C2, C3, and C6. Okay, and C6 being the high-end one, which we have got more special features, which I'm going to take you through the machine. Just to give you an outlook of the machine. So this, if you see, this is the machine screen or display. This is the ventilator unit, main part, and this is the stand and the trolley. And there is space at the back for the cylinders also. So you can connect this machine from the high pressure source of the cylinder. You can move the machine as well. The very important thing is that this machine does not have any air source. Okay, so you don't have to attach any air. Okay, I mean the wall air, or it doesn't have a compressor. It has a high-end turbine. Okay, or I would say that it has a high-quality turbine which has almost of a lifetime warranty. Okay, and when you say that lifetime means it covers almost 10 years in all the equipments. Moreover, okay, so in terms of turbine, you don't really have to worry. But then there are a lot of questions which arise for turbine and for also compressor, that which one is better, because some doctors prefer compressor, some prefer turbine, and there's a lot of debate which goes in between turbine and compressor, that which is better and all. But just to give a highlight, because it is turbine, in terms of your trigger delay, which is very much lesser in turbine. Okay, if you compare the compressor, in compressor there are more trigger delays. Okay, and in terms of the movement, the space, everything is less, because if you have a compressor, there will be big machine, and you also need more power, electricity to run this. This machine also has a battery backup of around 1.5 to 2 hours. Okay, also depends on for what brightness you have kept the machine. So like your phone, if you decrease brightness, you can decrease your battery backups. So at the back of the machine, I'm just turning and showing you. So we have attached right now this power cord for the main source, and there is only an oxygen source what we have attached. So there is no air source connection of which you see, and this is the air intake area. Okay, and they have mentioned here, do not obstruct. That means you don't have to really stick it to the wall. Okay, you have to maintain the distance of at least a feet, because it is going to suck the air from the environment. Okay, and there is a blower inside. Okay, where your O2 and your air is going to get mixed, and then it will be delivered. Now there are other things also which we have the options of communication board, which you can connect this machine to the screen as well, in case if you want to teach or train. And then there is a small connection to the display. So moreover, I will not go much detail here, because it is more of a technical and engineering part, which is of not of much clinical relevance. Now I will go to the main part. So this is a screen, this is a ventilator unit, and this they have mentioned here that this unit is with IntelliVent ASV, and it has got adult pediatric mode and the other features like PV2. The other machine also you have, there are two C6. On one machine there is no sticker for IntelliVent ASV, because you have in one machine only the IntelliVent ASV. In another machine you don't have IntelliVent ASV. And then this is a ventilator unit. There are options of your power connections, your battery charge, your alarms, and everything here. The alarm lamp is here. Okay, this outlook. And now comes the main connection. We have connected already here on the inspiratory and expiratory port, the two wings. Okay, and this is the expiratory valve, which usually comes in all the machines, if you see. Okay, this is the expiratory valve, which is removable. You can remove this expiratory valve. Once you think that you have used on an infected patient, you can send this for autoclave. You can remove it and then send this part to the autoclave. You can reattach it and then fix it. And if you notice with other machines, there are flow sensor at the machine end along with the expiratory valve. This machine does not have any flow sensor at the machine end. Okay, the flow sensor what we are attaching is here, which is the proximal flow sensor. I'll tell you that as well, why we do that. And now just to attach it is simple. Just a clockwise, it will be fit. And ideally your inspiratory and expiratory limb, we do have our coaxial circuit also, which comes in single limb and a small connection at the machine end. Okay, but you can attach any circuit. So I am attaching right now here the circuit. The very important is the flow sensor what we have. Okay, this is a proximal flow sensor we use. Just to show you the flow sensor separately. And the connection is simple. There is a color coding white to white and blue to blue. Okay, and there is no heated filament inside. So if you see other flow sensor of the machines at the distal end, they have got some heated filament inside, and you must be facing problems with them when as and when you nebulize the patient, you get damages, or again then you need to send it for autoclave, or you have to attach new like in other brands. But this does not have a heated filament, and this is a proximal one. And proximal flow sensors are more accurate in terms of measuring your flow, pressure and volume than the distal ends. Because first the machine gives the inspiratory, the air inspiration, and after the expiration, once it reaches to the machine, then it measures. But with this, what happens is, since it is near to the patient, okay, it is immediately recognizing the flow, volumes and pressure. So in terms of accuracy, it is more there. Also in terms of your trigger, it is most faster. We have also compared with other machines. We observe that those machines which have the flow sensor at the distal end, okay, have a trigger delay in comparison with the machines which have the flow sensor at the proximal end. The only thing is that we need to maintain it more diligently, because when we fix to the patient, it is always important to fix in an upright position like this. If I don't use this and if I attach the patient like this, if it's hanging like this, or in just horizontal way, then there are the moisture, the soiling can happen inside this, and it can damage the flow sensor. But this flow sensor what we are using right now is a disposable flow sensor. Ideally, we as a manufacturer do not recommend to reuse it, but in all the hospitals they do reuse it. It depends on the durability. Now, in that case, when you attach the flow sensor to the machine, I would always request you to keep it like this, so that there will be no soiling here. No soiling means you can use it for a longer time. There will be more durability. Okay, and of course, in comparison with other devices, you will not see a lot of breakdown of flow sensor very frequently. Okay, so this is the main importance of flow sensor what we attach. Other things, if you see here, there is the option of esophageal pressure monitoring. This is the blue port here. Okay, and there is the yellow one. What you see is the pneumatic this nebulizer. Okay, there's another thing what we have here is IntelliCuff. Okay, right now that machine, this machine does not have the IntelliCuff, but IntelliCuff we also have a device which can automatically measure and inflate the balloon of endotracheal tube and maintain the cuff pressure in that range. So suppose if you want the cuff pressure to be 20, you don't want to exceed that. So you set the IntelliCuff pressure according to that. Okay, it will get connected here. And suppose if there is a leakage, if the pilot balloon deflates, the machine will sense that the balloon is deflated. It will automatically re-inflate to the set pressure, so you don't really have to worry. And that way it can avoid your micro aspirations and ventilators with pneumonia, all that. Because sometimes what happens, we also forget to see the pilot balloon and we don't really observe the balloon that it is fully inflated or not. But this way, if you have this device additionally, it's connected, it will help you. But right now, as I said, you need a small device for that, which can be connected at the back, and then you can connect here. So that upgradation is not there with the machine form. But just to explain the port, that why it is given here. So I think the main physical part is understood. Here is your IntelliVent kit. So this particular thing is given mostly for the purpose of IntelliVent ASV. Why IntelliVent ASV? Because IntelliVent ASV is a fully closed loop mode where it takes the feedback from the patient in the form of EtCO2 and SpO2, and then it adapts accordingly. So suppose if your patient's SpO2 drops, okay, the machine analyzes that the SpO2 has dropped, and the machine automatically increases the FiO2 to reach that range what you have set. So I'll show you more in detail about IntelliVent in the presentation. Okay, so this EtCO2 and SpO2 is for that purpose. Similarly, if your EtCO2 you have set at a range of say 35 to 45, and if the EtCO2 increases to say 65, the machine automatically increases the minute ventilation to wash out that CO2. So just to complete the loop, okay, as a feedback. These sensors are important. Okay, so one sensor we anyways attach here. Now always remember when you want to attach a sensor, it should be after the flow sensor. Okay, so I saw yesterday in the ICU they have attached, in between this. So if you attach it here, that is more better. Okay, and so this is for that. And similarly, you have a Massimo SpO2 probe. Okay, it's same like your monitor, but you cannot attach the same to your monitor. It has got different connection. Okay, similarly, this has got different connection. Okay, sometimes we see that this might get connected to the monitor, so which we will recommend not to do this because it will not get fit properly and we might damage it. And there are other connectors also come like Nihon Kodan, but Massimo has more accuracy than Nihon Kodan and other brands. So that's why we have given Massimo kit. Now this is the physical appearance of the machine which is completed. Any questions? Physical appearance?
We can attach HMI filter.
Yeah. After this, yes. So after this, your HMI filter, and then comes.
Because of the moisture, water, ETCO2 screen.
So if you after the in the ETCO2, it will happen, but then you need to clean it and.
Attached like that.
But it happened like very frequently.
Twice.
So in that case, because ideally when you say HMI filter, we need to change in every 24 hours as per the guidelines.
Where should we attach HMI filter?
After this. After this.
Within
HMI filter and your catheter mount.
Yeah.
Okay. And then you connect to your this thing.
We don't use that anymore.
Just to show you. So this is how ideally alignment. So here you are going to connect, and then comes your catheter mount, and then you are going to connect to your
Okay.
Okay. And one more thing, this machine will give you the guide that how you want to attach on the screen. Okay, so I'll show you that. Now to start the machine, moreover, there is also a button at the back to start. But suppose if you don't want to use the button back, it's fine. Okay. Right now, what we do is we just start the machine from the front screen only. So just long press the power button. Okay. So once you long press the power button, the machine will start. We would have connected here also, but we don't have the cable
Which
right
is
now.
the other one button, sir?
At the back. So I just show you that as well. Here. I just turn that. This here. Can you see this?
Yeah.
But it can be operated directly from here also. Let's just connect. Yeah. So now I've connected here, and on the screen, if you see, it has. You can see that the battery is charging here. There's a small sign of charging also came. And in the initial, while it was starting, have you seen the QR code coming on this? So if you scan that QR code, it will help you to redirect to the Hamilton Medical e-learning modules. Those e-learning modules are absolutely free of cost, and it is just not written to Hamilton. It has the entire modes of ventilation. It has got phase variables, control variables, and everything very simplified in audio visual way recorded. So you can finish those modules, and you can it is good for learning for all the doctors and nurses. It is made for that because Hamilton also has an academic team which has made all these things in focus of understanding the entire ventilators and the ventilation modes and the entire ventilation in basics. Okay, in those modules you will see ASV, intermittent ASV, transvolume pressure, and the registration is free. So you don't really have to. You just have to register once with the email ID, and you can use the same email ID and your password what you create, and you can just see those videos. And those are like 10 minutes videos with audio visual presentations. Okay, so it is not like 20 minutes, 25 minutes if you don't have time. But when you're just free, you can just see for just 10 minutes, you will understand this. And then once you answer this, you get the certificate, and you get the. I think you also have the medical points attached to that. So you can just go to that website, and you will understand more better. So now when the machine is started, you see the screen something like this. The screen is visible to everyone. And the light is coming. I'll increase the brightness. Second. Okay. So we have understood the physical appearance. Okay. Now the main part. So okay. So I think you can see the screen. So once we see the screen is also rotatable. You can turn it like this, turn it like that. Okay. Just to have an idea. And as I said in abroad, we can also, I mean, if the power cable is long enough, you can put it on the table or you can hang it on the wall. All that things options are there. But right now, since it is for us, it is only for the bedside part. So there is no options being given, but it can be upgradable later if required. Now, if you see the screen, there are this is the user interface. Very simple. Whatever you see is what you get, or what you have to operate. You don't really have to go inside anywhere to select any option or see any option. There are knobs here. These knobs are very very self understanding. So you have your alarm silence button. Okay, this is your O2 enrichment port, like you get other machines. When you want to give 100% oxygen, you just click on that. Okay, here is the option of manual breath. This option we have given for screenshots. So there is an option here, a small USB port. You can attach your pen drive, and a high resolution screenshot of the machine will be saved. So if you want to take any case and you want to understand, you want to present that, you can take a screenshot of this. Okay, so attach a pen drive and just take a screenshot. So a high resolution screenshot will be saved there. Very simple. And then your power button, your nebulization part, and your lock screen. So you lock the screen and then it will not be, no one can touch that, but it's simple. Okay, so now that we have started the machine, now we have attached already the circuit. There is a small circuit guide also which is mentioned on the screen, which will be easy for all of you to understand that how to attach and what to attach where. And since we select the patient category, we only have this machine for now for adult pediatric category. Okay, so we attach the adult pediatric circuit, we attach the adult pediatric flow sensor. Okay, and after connecting, so you have attached to the inspiratory limb, the expiratory limb, the flow sensor connections as I explained already, white to white and blue to blue. Okay, simple connection. Okay, so once you finish the circuit here, then comes your other things. Now to just see this guide, if you open this option of pre-op check, because we need to calibrate this machine. Once we select on this pre-op check, there are options of leak test, flow sensor test, and O2 sensor. Now first we need to do the leak test to understand that this circuit what you have attached is not damaged or something like that. So we do a small leak test. So I'll just show you that leak test.
What is completed till now? You finished? What is the rapid support?
No, sir. So just started only.
Just started.
I was just giving the orientation. And with every flow sensor, you will get this connector. I'm sure that when you attach this, I mean Amrit must be knowing about this. So this is a small connector which makes life really easy to calibrate. Okay, so we connect this connector here, and this comes with every flow sensor. So as and when you open a new flow sensor, you will get this connector for this thing. So we have given the flow sensors down with the biomedical team, and they will have one kit with this. So why this? Because for turning the flow sensor for the calibration, it becomes easy. Okay. So right now I do a pre-op check, and there are two important tests which we need to do before initiating the ventilation. One is leak test, and another is flow sensor test. Leak test is just to understand that the machine will understand that there is no leakage in the circuit, in the flow sensor, tubing, or anywhere. Okay. So what we do is I just start the leak test. Just follow the instruction what the machine says. Once you click here, it will tell you disconnect the patient. Already disconnected. Now block the breathing circuit. I'll block it like this. Okay, now test in progress. So it is just analyzing that whether there is any leakage or not. Sometimes when we don't do and we don't know that there is any sort of leak, or the circuit is down or anything, and then we don't really pass the leak test, and we get alarms of leakages and disconnections. Now reconnect within circuit. Now the time and date is updated. So good thing is that you also know that when it was done last time. So we can understand that. But we recommend that we need to do this test as and when you change the circuit, or as and when you have a new patient. Because you have a new patient, you will have a new circuit, okay, and you'll have to calibrate the entire circuit again. But if you have an older patient, you have already done once, okay, the machine is on standby, no need to do it again. Okay, but if you are using it for new patient, if you are using the new circuit, we would request you to do the entire calibration again. Now the second test was flow sensor test. Now if you see, the flow sensor test here was done on 10th of April. Okay, so like pretty long back, and I start this again. Now in this flow sensor, it will give you the guide. Now the tubing and the flow sensor is attached already, and then your other attachments, which will come your HMF filter or your nebulization, T connector part, or your ETCO2 or catheter mount. I have attached for now all these things. Okay, so after this, I have attached all these things, and the connector you are going to attach it here. Why? Because it is going to calculate the entire dead space of this thing. Okay, but if you are in hurry, or if you really don't want to do all these things, you can also calibrate from here. Okay, directly from here. But we would recommend you to use the entire circuit and calibrate, which is much better because it is going to calibrate more accurately all the dead space. Now again, it is simple to follow this. Just click on this and start. Now follow the instruction, disconnect the patient. Now flip the flow sensor. Now this flow sensor has to be flipped from here, okay, to here like this.
That's the importance of having that small connector, isn't it?
Yes. So because it will make very easy for us to connect again to the main circuit. Okay. Even without this can be done, but then
just flip the
to flip this thing. And sometimes we lose it. We are still able to do it, but it becomes very difficult to hold with your hand and maintain that. So now if you see that it is in progress, calibration is in progress. Just see on the screen as well, because it will give you all the instruction. Now flip the flow sensor again. So you need to go to the original. Sorry, you need to go to the original part again. So you have attached it back how it was. Maybe I was a little late. Understood? Good. This is very important. So now you will get the date and time.
So why do you think this is important? I mean, he said it's very important. Why do you think it's important? I mean, just for the sake of understanding why this is important. Why is it important? Nikhil, what do you feel why it's important here? Why do you think it's important? But why for what? So because everything on this ventilator, you take everything on this ventilator, anything that you have with respect to the dynamics and with respect to the measurements are actually based on this sensor. Okay, because this is one of those sensors that gives you volumes. You understand? Now, otherwise, when you do ETCO2, you get idle carbon dioxide. When you do otherwise, it is the sensors are somewhere inside here. Okay, whereas here the sensor is outside here. This is the one that is giving you all your measurements, including something called as time constant. We'll come to the time constant. Okay, so that is the one that actually determines how the patient gets ventilated on any of these modes, including adaptive support, which we use regularly. Okay, if we have this ventilator, we'll be using ASVs like that. Okay, but if we are using ASV, to understand what are the parameters that the ventilator chooses, this is very important. You understand now? Huh? So if you don't calibrate this, the ventilator will do wrong things. Are you understanding? Huh? That's why, as he said, so when the patient is on the ventilator, can we check whether the calibration has been done? When the ventilator is going on?
We can check when it was done, but we cannot really calibrate while.
But say for example the ventilator is on start ventilation. Let's put it start. So if you are in your rounds and you want to figure out whether the check has been done. Okay, so say for example I go to start ventilation and now I want to check. So go to system, go to sensors
and calibration. And you can see that
even when the ventilator is on, you don't need to keep the ventilator on standby to figure out whether this check has been done. So now that you know the importance of this sensor, in your daily round, it is important for you to go back to this setting. How do you go back? I'll just show you once.
So we go to systems and test
and
calibration.
calibration, and then see whether it has been calibrated. So between patients, it needs to be calibrated. Okay, between patients, it's very important. Okay, or every time you change the circuit, we don't change circuit. So between patients, okay. You're not blocked.
No.
You are seeing.
We are just seeing that
seeing
whether
the
the machine
date,
is calibrated
seeing
or
the
not.
date,
We
whether the
cannot
machine-
calibrate during the ventilation.
You listen to what we are saying.
Yeah.
Don't sleep.
So we can only do this calibration when the machine is on standby. Okay, but you can, as such, that you can see when it was done. Okay, and it is important for also, because many a times what happens is that we don't calibrate and we attach directly, and like sir said, if the flow sensor is not calibrated, okay, and if there is some problem by mistake within the flow sensor, then it might give you inaccurate readings, it might give you, alarms, turn the flow sensor, calibrate the flow sensor, all these things.
So just one more question. If the flow sensor is not calibrated, then what do? We change the flow sensor? What do we do?
No, so ideally,
If the sensor says it's not passing the test,
it will give you alarm. That the
then
flow
what do we do?
Then we need to calibrate this. We need to put the.
No, if it's not getting calibrated, for example, we do everything
Mhm.
and the sensor says not getting calibrated, we need to change the sensor.
Yes, you do. In case if you, so in case if there's a damage in the flow sensor, it says that the flow sensor, it comes cross.
Cross, every time it comes cross, yeah.
Sometimes it comes cross here. When it
Uh-huh.
comes cross, that means there is some problem with the sensor.
We cannot do anything to make it right.
We don't make, Sometimes if it is too soiled and
Uh-huh.
if we are cleaning it and all, then it might also solve the purpose. But if it is damage or a crack or anything like that, then we need to replace.
So I would put it this way: see, if you have a patient who's going to have soiling with respect to blood and this and that, all, it makes more sense not to use this. No? It makes more sense not to use this. We use it at the later stage. Any which ways, when you have a patient on extreme acidosis or things like that, you don't use this ASV mode. Are you understanding? We'll come to ASV. When you come to ASV, you'll realize why you should not use it in extremely unstable patients. Okay? Yeah.
And to avoid soiling, as I said, we can put in upright position. Like yesterday, it was very perfectly
Yeah,
positioned.
so the problem is, it's very important, very important. This position of this is very important. It has to be like this. It cannot be like this. It cannot be like this. It has to be like this. Okay, to an extent that if you're keeping it like this, there is always a chance, when you're keeping it like this, okay, there's always a chance that the AC also might interfere with this. So at this stage, it makes sense to sometimes wrap it with some gauze piece, the whole system with the gauze piece, if there are problems that you can find on the ventilation.
And to avoid soiling.
To avoid soiling also. Okay, so to an extent. So if you, when in centers that you practice a lot of ASV and things like that, they normally cover this area. You see nurses covering this area with gauze piece. Okay, because it's so important. So never keep it like this, okay? Always keep it like this. Always and always. Okay?
If you keep it like this, you probably increase its durability. If
Yeah,
you use it
yeah.
for,
Longer periods of
period
time.
But if you keep it like this, hanging, and so it starts
So you
soiling.
basically use this arm properly. Use this arm.
So this is why the importance of support arm comes. Support arm, you can fix it, you can fix your tubings nicely, and it will be fixed very properly in this location. And you will see that, once you this thing. So now the operating part is over. So pre-op check you have done. The other part is the O2 sensor, which is more of an engineering part. The O2 sensor calibration has to be done once in a month, or as and when it asks. Or O2 calibration will ask you calibrate the O2 sensor. Okay. So that's simple. You just have to press it, and it will tell you with O2 supply less than 99%. So right now we are not attached any O2 supply, so it's fine. It will just calibrate the without you doing anything. You just have to press the button. Okay. So right now I'm not doing this. Okay. And it was done anyways on 10th of April. So we don't require it to do run now. We can wait for another month. Okay. Or as and when, because the machine may not be used also so much.
So as doctors in the ICU, you must understand that this machine is turbine driven. It's turbine driven. So there is no requirement of any gas. Are you understanding? The machine can work on its own. You don't need to इसको on off हम ऐसे ही कर सकते हैं, oxygen आते जाता है. You understand? You don't need to attach this to a circuit. You may be wondering, no, there is no oxygen, how it is working? Because this is turbine driven. You understand, na? So he is able to show this over here. Other ventilators, to show it, you need to attach it to an oxygen. Are you understanding? This is called, what is this called as?
Turbine.
So this also says that tomorrow if you want to transport a patient, if you want to transport a patient and the patient's requirement of oxygen is on the lower side, you may still be able to transport the patient from bed to bed. You understand? If you just disconnect it, and move the patient. If the oxygen requirements are very less, just move the patient from bed to bed. 100% oxygen तो तेरे को एक बेड से दूसरे बेड में लेके जाना है. Okay, don't try to disconnect and all these things. Just remove the oxygen ports. Take the ventilator from one patient to one bed to another bed. It is just a matter of 1-2 minutes, right? If that is the case, if the patient is stable enough, consultant says fine, then you move it like that. You understand? Because you put 100% oxygen, you have some time. Move from one to patient. This is in a stable, relatively stable patient. Okay.
So now we have done that. So once whenever the machine is on standby, you first have to select the patient category, then you do a pre-op check. Okay. I mean, anyways, we have only one category, which is adult pediatric, so you don't really have to worry that way. But certain machines, when we have the neonatal option also, it's very important first just to see also and put the direction of your mind in a way that when you on the machine on standby, first we select is the patient category, then we come. The next step is the pre-op check. Okay, and then we do the pre-op check, finish everything. Okay, now your machine is ready to use. You have got all the options right, and if you must have checked these two things, would hardly take 1 minute to do the calibration. The leak test finishes in around 15 to 20 seconds, and the flow sensor test finishes around 30-35 seconds. Okay, so not too much. So within a minute, okay, and we just we can do the test, and we can attach a circuit, calibrate the circuit and keep it ready before the patient is coming, so that your work is not you don't have to really do it when the patient comes in hurry. Okay, we can keep it and we can just keep it ready. So then once it is done, now comes to your main part of the options of modes. We have now modes. They could be different nomenclatures in different machines. So which is also important for us, that which mode is what mode, because you must be using other machines.
So before you go that ideal body weight now.
Yes, I'll come to that. Yeah. Just I'm explaining the nomenclature.
Yeah.
So now in terms of the modes, we have separately categorized the mode into volume control, your pressure control, intelligent ventilation, and non-invasive. Now in other machines, if I have to compare this mode, so maybe you are using say Drago, you have all the modes in invasive, you have all the modes in non-invasive. You just have to select mask or tube in the machine, and the names are different. So suppose if you want to use a CMV volume control mode, okay, which is what as per the Chad Burn classification of the names what we read in the books, and in Drago it is IPPV, right, or CMV, something like this. Similarly, so in the volume control category we have the CMV mode, okay, which is the volume control category. SIMV volume control we have similar to that. Then we have APV CMV. APV CMV, any idea what is it? It's a PRVC mode. It's similar to PRVC. APV stands for Adaptive Pressure Ventilation CMV mode. Only the thing is that the name is, the nomenclature is different, okay, but it is similar to PRVC mode. And I'll also share with you a small chart of mode comparison to understand that what mode could be similar. Then you have also PRVC in SIMV, so which is your adaptive pressure ventilation SIMV, which is a PRVC SIMV. Now if you want to compare that with other machine, you have IPPV auto flow. When you select auto flow options in your Drago, okay. When you have the options of auto flow, it's in the Drago you have options of PRVC in Mackay machines, so all different names. The only thing is that for PRVC, when you want to select, just select APV CMV. So this is your PRVC in your SIM, simple. Then you have your pressure control modes, where you have your pressure control ventilation, same you get in other machines. Then your pressure SIMV. Then your spontaneous. Spontaneous is your CPAP plus pressure support, if you want to compare that with other machines for weaning purpose when you are using. So only the name is spontaneous. Okay, and some machine it is mentioned PSV, pressure support ventilation. Some machine it is mentioned CPAP plus PS. Our machine is mentioned spontaneous. All the same thing. I'm just comparing the names. And then you have DuoPAP. Now DuoPAP is your bi-level invasive BiPAP. What was that?
So it is invasive. So beautiful that as doctors in the ICU, if you have a problem to understand, now if somebody asks you what is PRVC mode, so what's the control in PRVC? What is the control in PRVC? It's pressure regulated volume control. So remember, this PRVC is APVCMV. This is actually PRVC. Okay, so remember, it comes in the exam. PRVC is volume control or pressure control. PRVC is actually volume control. So if you look at these modes, you understand that this is volume control. You got the point what I'm trying to tell you? It's a simple thing. PRPC is volume control. Similarly, this is all BiPAP. What is BiPAP? Bi-level positive airway pressure. There are two types of BiPAP. One is biphasic, other is bi-level. Biphasic means, what is biphasic positive airway pressure? Biphasic positive airway pressure is when you're giving pressure in two phases of respiration, inspiration and expiration. For example, APRB. APRB is biphasic. When you say BiPAP, it may mean bi-level or biphasic. You should know what you are talking about. So if you are saying biphasic, it means in two phases of respiration, we are having pressures that are different. So for example, in APRB, you have one phase in the inspiration phase where the pressure is there, then expiration phase where the pressure is there. So it's called biphasic. Alright, so APRB is biphasic positive airway pressure. Right? When you say bi-level positive, which is the seen here, bi-level positive airway pressure, it means what? You have two levels of pressure. Okay, so it can be high pressure and low pressure. For example, pressure support plus PEEP. When you say pressure support plus PEEP, it becomes bi-level positive airway pressure. You are understanding? Understood or not? Biphasic is APRB, bi-level is what we are using, pressure support plus PEEP. It can be caused with various names, but you should understand what it is all about. Okay, so when you're looking at DOPAP, it is bi-level. Because that is why you have another mode called as APRB beside it. What is the APRB? You understand the difference? Understand?
And then you have the intelligent ventilation, which is ASV. Okay. Now, and we also have upgradations of intelligent ASV in this machine. I'll show you more in detail about this. And ASV and intelligent ASV both comes under closed loop ventilation modes, which I am going to show on the screen. Now, then we also have NIV, NIV-ST. Now, the difference is NIV is your plain CPAP plus pressure support with no backup rate. Okay, this is what you usually use in other machines. Okay, and so if you see here, there is support, PEEP, and your other synchrony settings. Okay, similar to CPAP plus pressure support. Now, if you select NIV-ST, that means you have your inspirator pressure, PEEP with the backup rate. Okay, and the options of setting the IE ratio as well in there. Okay, so there's a difference between, so it can be your bi-level, which is of non-invasive BiPAP, what you use, where you use IPAP and EPAP. Okay, in small setups of home care and all, in the small machines. It's similar to that one as a ST. ST stands for spontaneous by time. So it has a backup rate as well in there. So this is just the orientation of what more. So not AVAPs, because AVAPs you set the.
So I don't know whether you have seen with the earlier estimates, the earlier BiPAP, which we call BiPAP Vision, it was called. Earlier BiPAP Vision had these modes called as NIV-S and NIV-ST. Okay, what is happening with NIV-ST? Can you just switch this on? Okay, what you see over here now, by looking at you'll understand what it is. So NIV-ST. Let's go to NIV first. Just NIV. Let's go to NIV. So in NIV, what you're seeing is a P limit, a P ramp, a PEEP, and a pressure support. So this is what? It is a spontaneous mode. First of all, okay, it's a spontaneous mode where you are giving a maximum inspiratory time, at the same time you have a delta pressure support. You understand? It's like a non-invasive ventilator, which is basically the BiPAP, when we call bi-level positive airway pressure in NIV mode. समझ में आ रहा है? Bi-level positive airway pressure in NIV mode. You got the point? But when I go to tell me the difference what you are seeing in NIV-ST. Tell me what is happening in NIV-ST. What are you seeing in NIV-ST? What is the difference you are seeing here? Shall I go back once more? Yes, the rate is counted. That means there is a timed. ST means timed. It is spontaneous as well as timed. You understand? So the only difference is that in invasive ventilator and non-invasive ventilator, the leak compensation is different. Otherwise, the mode is the same. You understand? Understood this? So when you have NIV-ST, the only addition to the entire parameters is the rate. Understand? So if you don't understand any machine, just go to the mode, open it, see the controls. That is how you should understand. If you open the mode, see, touch it, and you see, that is how you will understand the entire system. Clear?
So now we have seen the modes of the machine.
We can shift it over.
And then we have the options of choosing the this layout of the graphics. Now this was again also very interesting. Now suppose if you want to initiate the machine, start the machine, you have already done the checkup, you have selected the mode. Suppose if I select CMB mode. Now what happens is the very important part here is your patient's height. What happens is when you set the height, the machine will, if you are using a normal conventional modes like CMD and where you want to set the volume, the machine will auto calculate for you the volumes as per 8 ml per kg. So suppose simple, if I select CMB mode, I confirm it. Okay. Now I set anybody's height. Can anyone just set normal height? What is that? 162. Okay. So 162 I do it. I get 59 body weight, and if you see my volume is automatically set at 470 as per 8 ml per kg. But suppose if I change my height to 170, now the volume has changed again as per 8 ml per kg. If you calculate that way, okay. But of course, if you want to change it, then it is on you. You can change and increase decrease as per your requirement. The only thing is that it is important for you to set the height is that initially sometimes in hurry we forget also to set the accurate this thing, but at least machine will give you 8 ml per kg of the volume if you are using the volume control mode. So that's why it's very important for us to set the height, probably in all the modes. It's very important. Okay. So now I set the height of the patient, suppose. Okay, and I'll get in the mode auto set with this. Now if I select this particular mode CMB, okay, already selected, sorry. So suppose the mode is already selected, the mode will come here. But if you want to change the mode, sometimes you get confused. I want to change the mode and I select say PCB. Now it is still on CMB. We haven't yet confirmed it. Okay. But you can see that we are on PCB doing the settings. We do the settings and then we confirm it. Once we confirm it, we get the set mode here. Okay.
Unfortunately, if you want to go back to the earlier mode, enter on the mode, that doesn't occur. See, like for example,
the previous mode is the same settings.
Yeah, it doesn't occur. So if say for example, I'll tell you why. So if say for example, I want to do a maneuver. Like for example, I want to do a low flow infection maneuver, and I now want to go back to my earlier setting from what it was. Okay. So it doesn't go to the earlier maneuver.
So what happens with this is because suppose you're on CMB and it's already attached to the patient. So what happens? The machine also analyzes the required pressure.
You understand? For example, if I want to do, say I want to do a maneuver, okay, and I just want to do a maneuver in that mode. Say for example, I'm on a pressure control mode. Now I want to do a low flow inflection maneuver for which I want constant flow. Okay, when I want to do a low flow, this is quite high five. Okay, so if I want to do it in other ventilators, what does happen is I can go to that ventilator setting. Okay, SIMV, say I want to do SIMV. I do the low flow inflection maneuver, and then when I press accept or finish, it goes back to the earlier mode. So here that is a limitation, but we don't have a problem because you anyways have TV loops in this. That way. Okay.
And the other thing sometimes is just to explain. Suppose if you are using the plain CMB, okay. Now there's an option of controls. Okay, when you say controls means the actual settings of the particular mode where you are. So you go to controls, so you are going to the CMB setting. Now say suppose example the option of flow trigger. We already have set a flow trigger, that means it's our assist control mode. You can keep it off to make it fully controlled. Off, okay. But suppose if you set a trigger, it is working like assist control. This thing now, suppose if I start the machine, say I'm trying to trigger. Now say suppose you are switching from CMB to PCB. Okay. Now suppose I go to PCB, I confirm it. Now you see the machine has automatically taken the pressure here. Okay. If the patient has a stiff lung, okay, high pressure requirement, okay, if I make it more stiff, the machine will automatically take a higher pressure. Okay. Similarly, when you switch from your assist control mode to your PSV mode, it also auto takes the pressure settings from the previous mode as per what the machine analyzes. Okay, I'll show you that as well. Just a second. So now suppose if you are on a spontaneous mode, now and another good thing with us is also that spontaneous mode, your machine is now the patient is triggering. Okay, the machine is giving the breath, fine. Suppose the patient stopped triggering. So whatever the apnea time you have set, 20 seconds. As per that, it will go on to the backup mode. Whatever in case we have set on the backup. Sorry. Second. So your apnea backup is already there inside. Now suppose, now in this, if you see, I have stopped breathing, and now in that case, you see the machine will go on the backup. But all the machines go on the backup, but it doesn't come back from the backup to the original mode what it was set. Now it went to backup. Okay, and suppose you are not there, and the patient start breathing again. So 1, 2, and 3. Within the 3 breaths, it went back to your spontaneous mode. So all the machines go to backup, but it doesn't come from backup to the original mode. This machine will also come back from the backup to the original mode.
That's the reason you don't see backup on a regular basis.
Regular basis.
Because it goes back to.
It goes back to this thing.
But does it keep a record?
Yeah.
Does it keep a record that this happened?
Yes. So you in the events you will have, when was what changed. Now apnea ventilation ended. You will have all the record in this. So yes, you have the time, date, and everything mentioned in the event here. Okay, when it went to backup. So backup settings automatic. Can you see? All these things are there. So yes, it will record for you all. It will record the data till 72 hours. So all the events will be there in this. Okay. And now other good features. I'll just highlight more features, then I'll go on the AST part. Now suppose if you are on any mode. Okay. So what we give is first this dynamic lung window. Okay. And this dynamic lung window is really helping us to analyze the part of tube block or any sort of obstruction. So ideally, if you have obstruction, you see the peak pressure, right? But suppose I create an obstruction here. Okay. So of course, the high pressure alarm will come. Your resistance here will increase, and also what happens is suddenly your airway, this airway, you see this airway, white color. This is right now in white color, blank. That is clear. But within few seconds, and as and when the machine analyzes the tube block, the entire airway turns to red. Okay, so it gives a visual impression that there's some sort of blockage on the airway. It could be a ET tube block. It could be soiled HME. Okay, now it is changing color. Now you can see it's changed. It's changed to red. Okay, so that means there is some sort of obstruction. It could be a mechanical obstruction, of course. Okay, or it could be also a spasm if you have ruled out all the mechanical obstruction. Now in that case, your resistance is high anyway, which means your airway turns to red, which is clearly showing you that there is some sort of obstruction issue, which you can match with your high peak pressure, which anyway is rising. And if you then suction or if you treat the block, if it is all there, automatically it will.
But why is CHP not changing?
So it is a mixed condition showing right now.
This is a mixed
condition. Because this is also constricted somehow. So even the shape of the lung, the shape of the lung right now is making angles. Can you see the angles here? Okay, I'll also show you those cards on the screen. Now these angles, since these angles are made, so if there are very less angles, now hardly there are 1 or 2 angles. So the lung is showing more stiffer. I change the lung setting again. I treat the obstruction. Okay, and within few seconds I will see that this airway turns to white again. So if we teach our nurses that, okay, I know that they may not be able to understand the high peak pressure, all the nurses may not be able to understand that high peak pressure is because of what reason, but at least if she or he sees this color changes, and if they understand, okay, there is some sort of obstruction, they can inform you all, and then you can troubleshoot the issue. Now if you see that the shape is changing, the angle is increased. So slowly again it's changing. Can you see? Now it turned from red to white. The shape of the lung is also changed. Almost it has got more angle. So that means your lung is slowly now opening. Okay. I'll try to make it normal to see. And when it takes exactly the actual shape, that means it is a normal lung mechanics. Okay. In the actual lung mechanics, it will take its original shape. So even the shape of the lung and the airway, okay, has a significance in terms of analyzing the patient's lung mechanics. Okay. So yes, values we are anyways watching every day, but even the visual. Now, can you see the blink of the orange diaphragm sign? That is a trigger. The patient is breathing. Okay, which you can match with the triangles what you get at the base of your pressure time scalar. Okay, if I don't trigger, then you will not see any blink of the diaphragm. Okay, there is no blink of the diaphragm, and even the triangles will disappear. When you trigger again, you will have the blink of the diaphragm. And this particular part is called as dynamic lung. Okay, and where you can see your patient's height, your ideal body weight, and the actual respiratory mechanics. And if you have connected the SpO2, it will give you the SpO2 and the pulse rate value also, which already we have here inside. Then comes to this window, which is weaning. Yeah.
Sorry,
No problem. Yeah.
my doubt may be silly.
Yeah.
So if my patient has a pneumothorax,
Yeah.
will
No.
So it won't
It
display.
won't, yeah. So it is moreover for the part of monitoring, and it will only explain you that how much is the resistance and compliance, and as per the changes to the resistance and compliance, it will show you the numbers and the image
So
that
it will show you poorly compliant lung.
Poorly-
But the graphics.
No.
That is, see, this is a pure nursing graphic.
Okay.
Say for example, you're walking. If you're walking, you just see, okay, ये लाल हो गया, there is something. Oh, इसमें angle ज़्यादा हो गया, there is something. It's not indicative of.
Yeah. It's not any sort of diagnostic.
I mean, I would put it this way: that's for the nurse. We as doctors should look at the numbers.
So as I said already, that
But as he says, it's very important to tell the nurse कि भाई ये दिक्कत हमको inform कर दो, because numbers is something that they are not used to. Pictures are something they are immediately used to. They immediately tell you.
So we'll also do this basic training for nurses to understand all this visual this thing. But it becomes easy for them to actually analyze and understand the issues. Now, other part is your vent status. Now, ideally for your weaning part, okay, we do note the weaning parameters separately in our notes. Okay, we note the tidal volume or the minute volume. We see how much is the FiO2. Okay, how much the patient is maintaining SpO2. But in this window, you have the entire important parameters for weaning as per the ventilator criteria. So we have for oxygenation, we have the FiO2 and the PEEP setting. Okay, for ventilation, it is taking the minute volume and the inspiratory pressure, and it is taking as per whatever the patient's demographic was set. Okay, this is set the upper and lower limit as per that, and if the sliders come in that range, okay, this is wide is a safe range. Okay, wide is the sorry, let's put this answer off. Now wide is the safe range, and the sliders are the patient floating, and there is a upper and lower value here. Okay, and there's upper and lower value, higher and lower value for all these things. So suppose if a patient is on spontaneous mode, you're trying to wean the patient, and the patient is on spontaneous mode. I do the least possible setting, which is say 7, 8. My oxygen is 21%. Now I start. Now my patient is triggering well. Now you will see that my floaters have slowly the fluids will be coming down. Can you see? And another important factor for weaning in the spontaneous activity we have given is RSB, which is your rapid shallow breathing index. This frequency divided by the volume, which we always see that as a value on the screen. Now this value will also come. Now you see the patient is 100% breathing on his own. I'm trying to get the RSB value. Now see, can you just time out? It just came. I'll try to get that. So since the volume is less, now this is a timer. Now this timer is an observation phase where it helps you record the time that for how long the patient was in this weaning zone. I'll try to get it again. Can you see this? So all this time will keep going and it will give you a, I mean, when the patient is on spontaneous mode, it will keep recording. So you will have a time that this patient was for 2 hours, you know, in this on spontaneous mode, was doing good that way, and you can take a call on your part of extubation and all. So there's another window which it gives and helps you also do that. So these are the two important windows which will get in all the modes ideally. Okay, which is your dynamic lung and which is your band setters. This comes under graphics section. So under graphics section, you can choose your layout. The default layout. The default layout is this one: 2 waveforms and 2 graphs. Now in these 2 waveforms, you get a pressure time scalar or a flow time scalar. You can customize this by clicking on the screen and change whatever you want. Okay. And so suppose you don't want this, waveform, because you have option of transpulmonary pressure also. You want to see the esophageal waveform or transpulmonary. What you do is you go to graphics, you change the layout to layout 1 where you get all the graphs. Now you got a volume graph, and now you can go down and get the esophageal graph, suppose. Or suppose you think that you don't want to see the volume graph because it may not be, very much significant for continuing this thing. So you can change this graph to the transpulmonary graph if you have the option. So you can customize everything, and it is very simple customization. Either you can click on the screen, okay, to change any graph, or you go to the graphics, okay, change the layout what you want. This is the biggest layout also for the mechanics. When you know that it is absolutely good normal patient, you only want to see the mechanics, and you can start this. But this is something which you only see this. So better either your layout 1 or layout 2, where you get the most important things, okay, which can be visible, and then you can change this. Okay. However, there is also a small monitoring window here. What is your driving pressure? This machine gives you in monitoring the driving pressure directly. You don't really have to calculate from plateau minus T. This will give you here directly. Okay. What is your compliance? What is your time constant? What is your idle body? How much ml per how much ml per kg of the body weight you are delivering? So right now, if you see on the machine monitoring, the patient is getting around 6 ml per kg of the idle body weight. So even that you will be able to see. Then now comes to the main important feature, which is your time constant. So I think also I've highlighted a lot about time constant. Okay. And this is the RCX. R stands for resistance, C stands for compliance. And basically when you say time constant, that means how much time the lungs is taking to fill and empty. Here we are talking about the expiratory time constant. That means how much time the lungs are taking to empty. Okay. Now in case if the lungs are taking a long time to empty, okay, which happens in your obstructive condition. So that means the lungs is going to take long time to empty. Similarly, the lung is emptying very fast. Okay, that which happens usually in your baby lung or stiff lung concept of your restrictive disease. In that, it is going to show a very short time constant.
So let me just explain to the physiology to get time constant. Okay. So time constant is very beautiful physiology. It's very interesting actually. Time constant. Very interesting it is. So in the exams also, time constant is something that you must know about. Okay. As an anesthetist, this was always part of the entire physiology of respiration. So what happens in a time constant? To put it short, to explain it. Okay. When you breathe, okay, you have to empty your lungs. Okay, usually the time constant is that amount of time that it is required to empty your lungs to 63%. That means only 37% is left back. That is the definition of time constant. So if your lung is 100% full of volume, okay, and you want to empty the lung to 63%, the time taken to empty to 63% is called as time constant. This is not a ventilation anomaly. It came from mathematics. This is integer mathematics का एक logarithmic होता है, उसमें से आया time constant. It is not really ventilation. Okay, so that's why that number 63% is important. So it is dropping from 100% to 63%. That means only 37% is remaining back. So now you must know, to empty the lung to almost 90% plus, you need 3 time constants. You need 3 time constants. 95%. You understand? That means 63% से 37% रह गया. अभी 37% में से 63% निकालना है. फिर बचा हुआ उसमें से 63% निकालना है. समझ गए? तो to reach 95%, you need 3 time constants. That is what time constant physiology is about. Clear on this? Clear on this? Now, the interesting part about time constant is that if your lungs are stiff, there are few things in time constant you must understand. Okay, if the lungs are stiff, it will enter and exit faster. It will enter and exit faster.
Normal time constant in your body is 0.1 to 0.2. Normal time constant in a normal lung. 0.2 तक normal lung होएगा. You understand what I'm saying? Normal lung. You put a ventilator, your time constant is bound to increase because you now have an endotracheal tube in place. You have created an obstruction. We know that if we reduce the lumen, there is going to be a creation of an obstruction. Okay, so when I create an obstruction, what should happen to the time constant?
Increase.
It should
Increase.
It should increase. So normally your time constant is 0.2. You and me are now at 0.2. The moment I put an endotracheal tube, the normal time constant becomes slightly abnormal. So you reach 0.4 to 0.5. You reach 0.4 to 0.5. Your time constant becomes now double, 0.4 to 0.5. This also explains to you that if I want to reduce my lumen of my endotracheal tube from say 10 to 6, my time constant is going to increase. I understand, it's very interesting. I have an MCQ in my book also on this. If you read that MCQ, it actually explains that. Okay, the time constant. So what happens over there is that your endotracheal, that explains why an endotracheal tube of a smaller size will be more difficult to ventilate because of the time constant. So you can generate auto peak. You understand? You can generate flow restriction. Okay, but it has to go in fast, come out, takes time to come out, right? Now, if you put one step further into this, if I put the tube, that means in this, the normal value when I am putting on a ventilator will be 0.5. If it goes more than 0.5, means the patient is obstruction.
0.5 to 0.7.
0.5 to 0.7. If it goes more than 0.7, okay, that means this is 0.72, it means this patient is in obstruction. You understand? But if the compliance is bad, it's a poor compliant lung, it will go inside quickly, but not completely fill. But it's very important to understand, not completely fill also. It will not completely fill. Okay? It will go outside also fast, you understand, and not completely empty. Low compliance. That's what COPD is. COPD is a generation of auto peak. Why does that occur? Going in, not filling completely, going out, not emptying completely. You understand? So the time constant is quick, giving it less time for it to exchange gases, and that's why your time constant becomes lower. You understand this very important physiology?
COPD time constant should
Obstructive disease, yes, but if it's restrictive COPD, for example, it is over like ILD, BLD ho gaya, COPD has become non-compliant lung, then what is going to happen over there?
Basically, ARDS physiology, time constant
Will decrease.
And obstructive pathology, it will increase.
So it's very simple. Now if you see this, let's create an obstruction here. Okay, let's create an obstruction here. So at this moment it's normal. Let's normal. Now what we're going to do is we're going to create an obstruction. Okay, we're going to create, say for example, we create an obstruction. Now see what's going to happen. Okay, it started changing. Okay, so you see a certain sound has changed, but let's see what happens in time constant. Okay, remember this every see what has happened. What is happened to time constant? So obvious it is that when you're creating an obstruction, you know the time
A
constant.
very
is
long time to come out.
See, if you look, you have to look at the lung. See this? See, the time taken to come out because it's passive is longer. You understand? However, it still gives you the whole tidal volume. It still gives the whole tidal volume. Now, if I were to make this restrictive, can you make this restrictive? If you make this restrictive, now he's going to make this restrictive. Okay, he's going to make this restrictive. It's very interesting, you know. You can understand physiology very beautifully. So you make it restrictive. Okay, you make it restrictive and you leave it this way. Okay, maybe I don't know whether you press it. Okay, so it's going to make it restrictive. So now, what I'm expecting, my time constant to
Decrease.
So you see what has happened?
Decreased.
Time constant has decreased. Moreover, you should actually, if the restrictive बहुत ज़्यादा restrictive अगर हो गया, तो volume will not completely empty. Volume will not completely empty. You must know this, okay? Volume will not completely empty.
Lung capacity is getting decreased.
Because lung capacity is coming down, no? Lung capacity is coming down. You understand? The compliance, lung capacity, elasticity. If the lung is not able to expand, since the lung is not able to expand, you know, and the time constant is very few, it stops at that pressure and then comes back. So it cannot really push the volume inside, because it will cause otherwise barotrauma or whatever, and it comes out quickly. So it doesn't completely fill. So why you must also understand this in the broader perspective of time constant is, That is the reason. In a lung like ARDS, there is going to be heterogeneous alveoli. We are looking at this as one single alveoli. This is one single alveoli. No, this is one single. It is not like there are multiple alveoli. It is one alveoli. Now, there could be a lung which has got different alveoli. One alveoli having one time constant, second alveoli having different time constant. Are you understanding? Huh? So, tomorrow if I want to find the pressure right here, it is easy for me. To find the pressure right here, it is easy for me. I go in inspiratory hold, I get the pressure there, that's my plateau pressure. I get the inspiratory hold. Now what happens otherwise? If you have say one alveoli that is compliant, one alveoli that is non-compliant, one obstructive and one restrictive, which is a possibility in all ARDS patients. Heterogeneous it is. We know ARDS is heterogeneous, it's not one single alveoli. I saw here. So now what is going to happen is a lung that is obstructive will fill and empty fast. Fill and empty fast. So the gas that's coming from there will fill this side fast, will fill this side less. Huh? You understand this? Huh? And when it's emptying out, this side will empty fast and it will get into this side when this is inner filling. It will tuck again, fill into this and then go out. This is called as pendiluft. This is called as pendiluft. And that is the reason that we have an inspiratory hold of 3 seconds for plateau pressure. Because you want to get through that pendiluft. समझ में आया?
The inner pores of cons.
Yeah. You understand what I'm saying? So अगर मैं inspiratory pause है कि 1 second में देखा, तो I will find only that pressure that is inflated those lungs that are kind of not really emptied and things like that. Goldman. So इसमें क्या what we are expecting in inspiratory hold that this lung has pendulufted into this and then together they are coming out. So that time limit taken is 0.3 seconds. 100 to 200 milliseconds is the time constant. Regular time constant is 100 to 200 milliseconds. So we are giving 5 times that number, almost more than 5 times that number.
At 5 times 100% fit.
So that 100% pendiluft has taken place and time constants have improved. That's why inspiratory pause is 0.3. You understand? That's why inspiratory pause is 0.3 seconds. It's very interesting, right? That's why when you're setting your inspiratory pause, say for example on a control mode, and you want to set a pause, it has to be 0.3 seconds. So there in the middle there was a guideline that came in ARDS that continuously monitor plateau pressure, and people started putting a 10% over here, and saying, okay, now I'm getting plateau pressure. Now you check the plateau pressure right here. Where's the plateau pressure? You get a plateau pressure here. That's a plateau pressure. But that's 10%. It has to be at least 0.3 seconds to get the idea. You understand why it should be 0.3 seconds. So you have to calculate that 10% or if it is 20 or 30, you have to calculate that percentage and give you 0.3 seconds. Otherwise, it is not finishing the pendiluft mechanism of the time constant. You understand the physiology now? You understand physiology? And why are we getting this time constant? It is because this flow sensor is there at the proximal end. You will not get it on other ventilators. And to remember time constant, the equation is R into C, resistance into compliance. That's why the name is RC. So you have time constant in inspiration and you have time constant in expiration. What you are seeing is time constant in expiration. That's why it's RC EXP. Clear? Clear on this? Any doubts on this time constant?
You have mentioned that time constant is the time required to empty the lungs is 67%.
To empty the lungs,
63%.
to remove 63%.
So that time is normally 0.2 seconds for us. If we put a tube, it will increase to 0.4 seconds.
0.455.
So if it is the expired time constant. It is the only one time constant. You also mentioned that the time constant is almost more than 95% empty. Means it is
That is 3 times.
3 times.
Yeah.
This RC expiry,
Yeah.
it is 3 times.
3 times. This is the 3 times.
So if the it increases by 0.2 to 0.4 because of tube for only empty the 63%, then to empty the 95%, it will be about 3 times the 0.4. Means it should be 1.2.
No, 63% of that amount. So if say let's take the example of 100 ml. Let's take 100 ml. And now you have one time constant. The remaining is 37 ml.
Yes.
Right? Now to empty 63% of 37 ml, maybe around 30 ml, 25 ml will come off. That time is lesser, much lesser, because it's only 25 ml. You understand? And then वो 25 ml से भी और कम करके उसको 5 ml लाने के लिए, that time is even more lesser. That's why it's not a 3 times. समझ में आ रहा है? You understood? समझ में आया? Finish. Understood, right? Huh?
So basically every time the amount decreases, so time also decreases.
Yes, because the amount of volume is lesser, no? The amount of volume is lesser. So the volume is lesser, that's why it's taking lesser time. But what you must understand, why am I explaining this to you? Because when you're actually going to do volumetric capnography, when you're doing volumetric capnography, I mean, there is, you know, this machine has got volumetric capnography. Okay, this is the penultimate capnography they can think of. Volumetric, we'll come to that and we'll probably going to show you volumetric capnography. Go to show or no? Too much for you.
Too much for today.
Okay, we'll go to.
We'll again bring on Thursday. So,
So just to complete it, volumetric capnography means the volume of carbon dioxide coming out. Okay, that will actually depend on the time constant. That will actually depend on the time constant. Yeah, are you understanding? Huh? So if I put a PEEP and I overdistend the lung, my compliance is reducing. Since my compliance is reducing, what will happen to my time constant?
Decreases.
It will increase. Since my time constant will increase, what is going to happen to my PCO2? The slope of rise will actually come down. It will become lazy. The slope of rise will become lazy. The slope will not be there. The carbon dioxide slope is phase 3 इसको बोलते हैं हम. In ETCO it's called phase 3. In volumetric capnography it's also called phase 3, but it is different. The waveform is different. Okay, the waveform will actually remove the slope and become slow because it's going to take longer time. You know, it's going to take longer time. So, by looking at your volumetric capnographic trace, understanding time constant, you can actually say whether the PEEP is adequate or inadequate or not adequate or over distending. We'll come to that when we actually do volumetric capnography. This is a beautiful technique.
There are a lot of things in volumetric we can observe, like PEEP, ARD, understanding ARD, sepsis.
Yeah. But you understood time constant, right? And this is very important because in this ventilator is only one of the few ventilators that you can do time constant. There are other methods also. I mean, this is not the only method. Don't think that this is the only method. There are other methods, and that is a completely different discussion where you can actually freeze the waveform on the expiratory flow and actually put it into an equation and give you a time constant. Okay, there are other ventilators which are proprietary, which actually do time constant with that technique. But however, the right technique would be to actually figure out time constant right there, gold standard. Okay, that's why this time constant that you show over here is only available in the Hamilton because it's proprietary and patented. Okay, huh?
So imagine when we have a patient in emergency, we attach the machine, and we don't know whether the patient is restricted or obstructive. We just see the value. We understand. We have an idea whether the patient is in a restrictive condition or a obstructive condition. So now, sir already explained this part of time constant. This too I explained. Moreover, the part of graphics I have shown you. If you want to, these are the main monitoring parameters what you see on the screen. Other monitoring parameters you can see in the monitoring tab. But suppose if you want to customize this, okay, one has to note the password, okay, which you have to just go inside and change as per what you want. So suppose if you don't want any particular parameter on the main screen, you can change it. For that you need to go to tools, you go to configuration and put 7132. Okay, enter.
Do you show me that measurements also?
Which one?
Monitoring.
Monitoring.
So,
I have showed driving pressure also.
I showed driving pressure, but of course, this driving pressure is not the right driving pressure because you need to do an inspiratory hold. Because you know now how many seconds you require 0.3. So this is not going to be the actual driving pressure. But, if we
The occlusion pressure.
but you don't have dead space on this.
That space will come when you attach the
CO2. You attach CO2. So you will also get dead space on the ventilator, okay? And that's, I forgot to tell you, when you are doing volumetric capnography, you can actually monitor your dead space. You can get your dead space. Are you aware that dead space is there even on your normal ventilator, that is GE? You are aware, right? We have shown it to you all. I have shown it to you all. Have you all seen it or no? On your GE ventilator, have you all seen? I have shown your hemocalc and shown you all. तुमको याद भी नहीं है, तुमको दिखाया मैंने, तेरे को याद है? हाँ? So on our usual GE ventilator also has volumetric capnometry. it does not have volumetric capnography. Okay, so when you have volumetric capnometry, you have a number. When you have volumetric capnography, you have a graph. This ventilator has got a graph. Okay, this ventilator has got a graph. Our GE ventilator that we are all using has got volumetric capnometry. Okay, so in that, dead space comes. How do you do dead space over there? What is the equation for dead space? Any idea? PaCO2 minus PeCO2 upon PaCO2. That is your definition. PaCO2 minus PeCO2 upon PaCO2. That is your definition. PaCO2, arterial carbon dioxide, minus end-tidal carbon dioxide. PeCO2, not end-tidal, ECO2, that is not end-tidal, it is end carbon dioxide divided by PaCO2. Okay, so our machine, because our GE ventilator has got a metabolic monitor, it actually figures out the volume of carbon dioxide coming out and gives you the dead space. You understand? So all you have to do in your machine is to actually key in PaCO2. You have to key in PaCO2. That you do a blood gas. If you have a blood gas that says PaCO2 is XYZ whatever, I've shown this to you. I've shown this. I've pressed that emo calc and shown it to you. So you can go there, put PaCO2, and you will get the dead space. Are you understanding? Beauty of that versus this. Beauty of that versus this ventilator. There you need to put a PaCO2. Here you don't need to put that PaCO2 because it's got a graph that is analyzing everything. Are you understanding? समझ में आ रहा है मैं क्या बोल रहा हूँ? So there what happens is you take a blood gas, the moment you get a blood gas, PaCO2 you see on the blood gas, you go to the monitor, you open up HemoCalc, okay, fix equation, dilution, whatever is cardiac output and all you want to find, you can find cardiac output in your GE ventilator. Go there, put dead space, put your PaCO2, you press a button, you know this, right? Don't you remember this? You have not done it because you are not doing it. Okay. So put it, you will get your dead space. Are you understanding? You will get your dead space.
With this ventilator, how that ventilator getting PaCO2?
How this gets the PA? So you need to not only have PaCO2, you also have to have PETCO2. So this is not looking at the very famous Bohr-Engelhoff equation. What I'm talking of is the Bohr-Engelhoff equation. So that is not looking at the Bohr-Engelhoff equation. What is this doing? It is plotting a capnograph. So what this is doing is, so it's very interesting, no? So for some reason, the more I read, the more I like it. You know? So even if you read more, you like it. Okay, it's as interesting as that cover this physiology. So PaCO2 minus PeCO2 upon PaCO2. This is your dead space.
Sir, this PeCO2 is not the PeTCO2.
No.
Okay, so how do we get the?
This is exactly what the machine does. Because these machines, so what you understand the question that he says? The question is this EtCO2? It is not EtCO2. This is the volume of carbon dioxide. When you see EtCO2 is partial pressure. We are looking at the volume. So these monitors, these ventilators are so hi-fi that because of all these sensors, integrations that they have, and in the GE you have the metabolic monitor, it is able to tell you the volume of carbon dioxide which you see as VCO2, no? VC1, VCO2 there. We see VCO2 in that ventilator. That VCO2 is actually the volume of carbon dioxide. It's so beautiful, isn't it? Huh? It gives the volume of carbon dioxide, and that volume of carbon dioxide is what is put away. Because after all, the dead space is VD, volume. It's not pressure. You understand? So if you want dead space per proportion, it's VD by VT. Dead space by tidal volume. You understand? So I need volumes. So it looks at this and gives you volumes. Now this is the equation, right? So our GE ventilator uses this equation, has got the VCO2, PaCO2 you are adding, you are putting inside, and then it gives you VD by VT. Which in this machine is calculating, otherwise the importance of this machine is when you are putting ideal body weight, no? It is actually even calculating a dead space with the mathematics, 2.12 ml per kilogram. Initially it is looking at a dead space by 2.2 ml a kilogram. Initially. Okay, but otherwise how does it calculate? It then makes a graph. This is how a graph of volumetric capnography looks. Okay, that is the amount of volume of carbon dioxide that is getting picked up and getting to its maximum. We got the point. So initially what is going to happen is, when the expired gas is coming out, this is all coming from the
area that has absolutely no relevance of gas exchange. So this is anatomical dead space. Okay, this is anatomical dead space. Then there would be a phase 2. This is phase 1. Say like this is phase 1. That is phase 2. So it's phase 1, and you have phase 2. Phase 2 is that place where there is going to be a mixture of anatomical and physiological, which comes somewhere here. This is anatomical and physiological till it reaches a certain zone. And then after that, the entire thing is alveolar. So in short, this area is volume of alveolar CO2. That is how it recognizes volume. It does not have a metabolic monitor. Okay. Then what it does intelligently, there is something called as Fowler's equation. Fowler, actually this was long ago. This was already discovered. It came into practice only when Hamilton were able to pick up something and let us know what it works like. So there was a Fowler's equation where he found out that when you divide this into two parts by a certain equation, you have a part of the anatomical and part of the alveolar. So now, if I put this whole place into place, this becomes dead space, physiological dead space. The whole thing is together physiological dead space, alveolar dead space. Alveolar dead space, and this is the total graph where this is the alveolar dead space. This up to here is alveolar dead space. This, when you add to this part, becomes, this is anatomical dead space. And when you put both of them together, this becomes total dead space. Are you getting the point how it's doing it? It's creating a graph with respect to volume. On that volume, it is figuring out, putting this line in the middle called Fowler's equation. Okay, and then coming to a conclusion that okay, this is the volume of alveolar dead space. This is the volume of VOC/CO2, that is volume of carbon dioxide that is getting exhaled out, volume. This is giving you the physiological, this is giving you the alveolar dead space, okay. This is the anatomical dead space, okay. You understand? And this entire combination is the physiological total dead space. That's why it is the dead space. So you can actually look at the graph and understand whether my PEEP is okay or not. So if I want to increase my PEEP, what will happen? Let me explain to you what is going to happen to the PEEP. What is going to happen if it's over distended? Compliance ko kya ho raha hai? Compliance is decreasing. So if compliance is decreasing, what is going to happen to the removal of carbon dioxide? It will become slower. It's not removing out carbon dioxide because it's going and coming out fast. It's not removing out carbon dioxide, isn't it? It's not removing out carbon dioxide normally. So the slope will become lazy. And rather than the slope going up like this, it will go slower like this. Because it's not really removing out carbon dioxide properly. You understand? That's why the pendulum push must understand. That's why the time constant must understand. That's why you must understand RC. Why when the RC expiration becomes low, why? Are you understanding? So this area becomes bigger, which basically means that you are increasing alveolar and physiological anatomical dead space. Are you understanding this? Meanwhile, if there is bronchoconstriction, what can occur possibly? But usually we don't have just bronchoconstriction, we normally have a combination. But this is how you can adjust PEEP. You understand? So if your PEEP causes this, what will you assume? If PEEP causes your graph to go from here to here, what will you assume?
CO2 is not eligible.
Means what?
Over distended.
This was your PEEP of 6, this is your PEEP of 8. But you saw the graph becoming like this. What does this mean?
CO2 retention.
What does this mean? This has become slower. Removal of carbon dioxide has become slower.
Yeah.
Means what has happened to your RC-EXP? RC-EXP time is increased.
Yes.
RC-EXP time is what is not increased, reduced.
Because compliance.
Okay, because it's not exchanging properly. वो अंदर फास्ट अंदर बाहर जा रहा है, तो एक्सचेंज बराबर हो नहीं रहा है, इसलिए कार्बन डाइऑक्साइड बराबर निकल नहीं रहा है. तो क्या हो रहा है कंप्लायंस को?
कंप्लायंस कम हो रहा है.
कम हो रहा
अगर
है.
कंप्लायंस कम हो रहा है तो मतलब क्या हो गया?
Time constant.
ओवर डिस्टेंशन. You are understanding or not?
हाँ, yes, yes, yes.
So volume under the graph is dead space.
No, this is volume of carbon dioxide.
Yeah. So it will decrease.
Dead space is this one. I am drawing
Yes,
three
yes,
times to it.
yes, yes.
Dead space is this one. This is dead space. Alveolar dead space. Anatomical dead space. Combination is total dead space.
So this graph displacement happen also in high potential.
It will no, so there are many other reasons for it. We are talking its application in PEEP. We are talking its application in. There are many other reasons to do it. For example, tomorrow you want to see whether your prone position is helping. Take the patient, put in prone. If the graph goes from here to here, if the graph goes from here to here, it means that now there is more carbon dioxide that is coming out. There is more amount of improvement on the volume of carbon dioxide. Are you understanding? The volume, you will get the volume saying that your prone is, this patient is prone responder, which is 2003's Gattinoni's paper. 2003, not now, 18 years ago, Gattinoni said that if the patient responds to a volumetric capnography, he is a prone responder. You understand? So when we were doing our this, I used to look at this to see, are ye to response ho raha hai. Are you understanding what I'm saying? Huh? So you can actually figure out whether the patient is one of the ways to figure out prone responder. They will call it as PCO.
Improvement in the gas exchange.
External gas exchange, exactly. Because now the RC expiratory is changing. So you have opened up alveoli that were previously collapsed. Since you opened up alveoli that is previously collapsed, the compliance is changing, and since the compliance is changing, this volumetric capnography is showing improved gas exchange.
It's very nice to see also.
Yeah, it's nice. Wow, it's looking like that. Moment, acha ho raha hai. It's working. That's how you think. You know. So it's not that it's not an all or none. So remember this. No monitoring is all or none. Whenever you are looking at any monitoring, you have to look at the context. This is an added information. So, for example, as Dr. Jairam said, what if the blood pressure is on the lower side? It has suddenly gone low. This is going to change. This is going to change because if the blood pressure is going to go low, the exchange of carbon dioxide will probably reduce because it is low hypoperfusion. Are you understanding? So you just don't look at one parameter. You look at this parameter in the context of everything. Okay, you cannot. So tomorrow, if you have a patient who's got very low FRC, and you try to do all these things, it may not work. हमारे FRC इतना कम है तो कोई exchange नहीं वाला को समझ में नहीं आएगा. You understand? In short, such FRC does not exist. That FRC is so small that no gas exchanges are happening. But I'm just telling you on a theoretical perspective. Whenever you're looking at any monitoring tool, any machine, it is not better than the human mind. Nothing is better than the human mind. You give the best machine to a fool, the patient behaves like a fool, the doctor behaves like a fool. You understand? No monitoring device is going to improve mortality. No monitoring device is going to improve. This is only going to improve the way you are going to treat your patients and do the right thing. You must understand that. समझ में आ रहा है?
So you told that there is a prone responder. To check that this is a prone responder, you have to press the button, capnography graph before proning and.
So what happens is whenever you're working, your eyes get tuned to something looking like this. If you're going to work with the volumetric capnography, you end up okay, this is good, this is good. And also you have the numbers. VCO numbers are also there. You know, VCO numbers are also there. So you'll be able to look at the VCO numbers. At the same time, your eyes get tuned to the slope. The slope. You're worried about the slope. This slope is what you're worried about. The slope is you can just understand. Wow, this is how it is. And you can freeze also if you want. Whatever you want, you can do. It depends on how you want to do it. As a clinician, you have to develop the way you want to do it. The easiest method is to look at it, turn, look at it again. Easiest method. You want to freeze, do what you want to do. You understand?
We have a reference loop.
Yeah. Like if you go here, this is the volumetric capnography. Where do you get it from?
CO2 is not there.
We go to the graphics. Sorry. We go to the screen. Go to loops and volume of CO2.
Volume of CO2. This is volume of CO2. Press this and you get a graph.
Right now
Actually, you can't get a graph because there's no carbon dioxide.
Carbon dioxide.
There's no carbon dioxide.
Then I have the.
So if you see the x-axis is volume. X-axis is volume. You see that? You see x-axis is volume. So as it goes up, like this it becomes, this is the volume. You understand? That's the volume. So the end of it is the total volume of dead space. So and that's your time constant. Yes, change it. Or not time constant, it's percentage of fraction into that data. क्या कर रहे हो? Okay, आ रहा है क्या? नहीं वो तो alarm. You know, you should actually have a demo mode for CO2 here, whenever for teaching purposes.
Right now we don't have it.
You should have it. You suggest
Right now,
it.
as in, yeah. the
Suggest it.
DJ,
वो भी अटेंड कर रहा है.
So, I think moreover the machine part is over. I'll just show you more 2-3 tabs. Okay. So I'll just finish more 2-3 tabs. Monitoring you have seen, but these are main monitoring parameters. Just to change, as I said, go to the tools.
Are you going to ASP now?
Yes, sir. I'm going beyond.
Let's start.
Just 2 minutes. Just recommend this password 7132. Enter. Go to configuration and go to graphics. Change. Whatever you want. Okay, you can.
What's the number you said?
7132. It's all. I mean, same for all the instruments. So once you go there and then you go to graphics and then you get the main monitoring parameters which you saw on the right side, and you can change according to this thing. And very importantly, if you always keep RCX from this thing, so like it, you can scroll.
Acha, there are lots here. So I heard there are when I was doing when I gone for the training for this now, there are more than 80 parameters on this. 80 that you can actually see. It's a lot.
And then once you fix it, you get the same here on the screen. I think moreover, if you finish the events, as I said, you will have almost a log of 72 hours. Who changed what? I mean, not who, but
So
when
has the EHR been can this be seen on my mobile now? Has it started? EHR
No, not yet. I think we spoke yesterday with Siddharth, right? It was-
it's coming out.
But it will come out.
So this will probably go to your EHR EMR. So you know exactly what's happening and what time to change what.
But on the events, you will anyways, see what time, what you have changed, and what was this thing. The other thing which I forgot to also say that all the alarms also has a troubleshooting guide. Suppose if you have a high minute volume alarm, if you click here, you get the guide for it. Okay. Even though ventilators give you guide for alarm or this thing.
No, it gives.
No,
Avid Excel gives, yes.
Avid Excel maybe giving.
Yeah.
But so in that, if you just click the alarm, and if your nurse is also there, if she doesn't know what exactly to do, she can click on the alarm. And
In fact, the Evita Excel has got a whole book inside, manual,
in the
inside the machine. Evita Excel, tomorrow if you want to understand what is BioPAP or what is BiPAP or whatever, you click on BiPAP, it will give the whole manual for you in front of you. You can read it.
and you will get the manual when you get the when you start the machine, you get the QR code, so you can get it in your phone once you scan that. But this is just for immediately when you get an alarm, you click on that alarm and you get the troubleshooting guide what to do for that alarm. So that is it. And then the last is systems, where you can change your this is your sound. You can decrease it to how much of it is comfortable. More the default setting is 5, which is something good or nicely audible. There's option of day and night mode where you can also put automatic. Once you put automatic in the night time, your screen light will become a little bit dim. Okay.
Sure.
So basically in the night,
This becomes
this little bit dim. So automatic में ये automatic लिखा रहेगा.
So
Particular
even
option
our Traeger has got a night mode. And Traeger has also got a night mode. You can just put it to become black.
Yes. And similarly here also you can change the day and night part. If you want to do it, this is automatic, so it will automatically happen. But if you want to do it manual, you can select that. So this is more about that. Then there's option of nebulizer. Now if you're using a pneumatic nebulizer, you're connecting it here. But if you're using erosion also, we do have options for erosion. Right now it's not inbuilt with this. But you can use your normal erosion, what you connect with the
So if you apply erosion, do you have to press anything?
Sorry, sir?
If you apply erosion in line,
No, because you are going to use the controller of the erosion, no? The controller which comes.
so you don't have to press anything.
You don't have to.
You do not change anything, no?
Yes. But for pneumatic, you can sync for your inspiration, expiration.
No, but if you put erosion, it will not interfere with the flow sensors.
No, sir.
Erosion does not.
Erosion-
Pneumatic will.
Pneumatic will.
Pneumatic will.
But also, like in other machines, you need to remove the flow sensor,
No.
divide all that things you don't have to do with this. And you can also sync the nebulizer. So what happens is also here important in the nebulizer. If you only start on inspiration, so while the inspiration happens, then then your drug deposits.
So please understand this. Pneumatic nebulizers, when we call when you call it pneumatic nebulizers means it's running with air. Okay, that means you put the circuit to oxygen or air or something like that. It goes from here, sputters and gives the gas. This is continuous. This is continuous. You understand what I'm saying? It's continuous. So in any ventilator, when you press nebulizer, what occurs is it allows the gas to go in only during inspiration. In any ventilator. If you press, so if you're going to use a pneumatic nebulizer, because it's going to be continuously on, it is important to press the nebulizer. You can't just put the nebulizer and leave it. If you put the nebulizer and leave it, it will just keep on giving inspiration over expiration over expiration over expiration. It will just keep on leaving. And what will that do? Because you're doing it in expiration, it will go and clog the expiratory sensor.
And also, it will also there will be a lot of also drug waste.
Drug waste will occur. Half 50% of your, not 50%, 70%, because expiration is longer than inspiration. 70% of your gas, 70% of your drug will get lost in the circuit. Okay, that's why when you are putting a small volume nebulizer which sputters, you press the nebulizer button on the machine. You understand what I'm saying, right? Similarly, on this also it is the same situation, but it is not the situation with AeroNeb. With Aerogen or AeroNeb, it is breath actuated. And since it's breath actuated, you don't need to press any nebulizer on that. It actually synchronizes with the breath. So tomorrow when you take a nebulizer, you breathe into it, you get it. You don't breathe in, it will not come. That's breath actuated. So the ones that we're using in the ICU are vibrating mesh nebulizers, which are the breath actuated nebulizers. समझ में आ रहा है? You don't need to press anything. And because it's not giving any gas and not connected to any source, there is no changes in the parameters. Otherwise, what happens with the pneumatic nebulizer is when you put the gas through that, you need to alter the alarms. The ventilator starts alarming.
And you can do synchronization for inspiration.
Clear?
And when you also attach AeroNeb, you don't have to actually attach the adapter in the socket. You can put here. There's a small USB port here. Okay, so instead of putting on the adapter the power cord,
Okay, there's a port here.
this is a USB port here.
Okay. So there's a USB port here. You can charge your mobile. What are you asking?
You can try.
Maybe you can. Go, more place to
But
charge.
for this is mostly for the screenshot. So if you want a high resolution screenshot of the device, you put a pen drive, it will take exactly the screenshot of this. So if you want to study or something, you want to put a case here or something, you can
That's how we did it, no?
Yeah.
For our EIT.
For
study.
EIT, yes.
For our study of EIT and all these things.
So in EIT also you have the screenshot
Yes,
of
screenshot
similar
of
that,
that, yeah.
and it's simple, just inside a pen drive, and there's this button is here. Can you see this here? Okay. If you click it, it will go green for seconds. Okay, and it will automatically save the folder in your pen drive as screenshot.
But how many times it shows? Just that or some minutes?
No, for seconds, sir.
Just
for
some
5 seconds.
Not a video.
Not a video.
Not a video, just a snapshot.
But there is also a small device where you can also record the entire video.
Okay.
Okay. I mean, so but which is a separate device. We can connect here. The
Can you get that device?
So that is वो बाहर वो दूसरा normal device है बाहर का जो हम लोग use करते हैं.
मेरे को अनुभव लगा था because we will then give you some good graphs
Yeah, yeah.
that we can actually
I will try that, yeah.
Huh?
So even the high resolution screenshots can be then done. And Aerogen, as I said, Aerogen you can connect here. That will be easy. So
Yes, people don't know that Aerogen can be connected. They just want to connect it to the
okay. To the main
main sockets. Yes, all that.
We'll do that today. So here it was an entire overview of the machine, the outer part, the entire software part. And we can have a group of Asia where if you have any questions you can put in there. I mean some queries. We have already made the groups of different hospitals where our machines are there. So if you have any query you put there and we just try to respond there on that group. That will be easy for
We have
them.
the group.
No, we are going to make
We
it.
will make a group.
Yeah, we'll make a group for.
That's good. So if you have any problems, immediately you can put it on the group so that everybody knows.
Everybody knows also, and moreover, if
Everybody learns. So let
we
us
have to
put it on for a
respond.
year at least,
And
so
on
that
the-
all of us gets used to the number of queries.
On the group, I will share with you the documents of all these things also, like volumetric capnography, VST, all that things, all the PDF files and all. So now I think we'll go to ASP.
Yes, I think so. So you can start the ASV, but I must tell you that ASV, when we started with ASV a long while ago, it's not recent. Okay, it's been a while since ASV has been there. In fact, it's been since 1970, and the guy who did it is actually on Tehrani. His name is Flute Tehrani, no? Flute Tehrani, no? Who's done this ASV? I think you can start taking coffee. Meanwhile, Flute Tehrani is this guy.